Hello, everyone. I'm Tua Pell. Welcome to our December 2023 ICARE Genetics Case Conference. So we're really excited about today's case conference, but I first wanted to start with some housekeeping. So looking at ICARE referrals, I wanted to give a shout out to Advocate Health, which is one of our newest partners who are amongst the top recruitment sites for November of 2023. And then you have the top ICARE recruitment sites overall for this year and the case conference attendees. Again, everyone knows what our website is. We try to make it super easy to refer to our registry. So please continue referring like you already are. On top of that, if there are cases that you want to present for expert feedback, please continue to submit them. We've tried to make it very easy through the REDCap link on this slide. Just some highlights of ICARE focused efforts. We're still continuing to partner with Drs. Kelly Metcalf and Stephen Narod on the hereditary breast cancer treatment study. And again, we've got large numbers of PALB2, ATM, and CHEK2 carriers. We continue to work with Dr. Mark Tishkowitz in the UK on PALB2 related efforts, and then looking at genomic characterization of inherited breast cancer gene carriers who've developed breast cancer. Again, that's something that I, along with my colleague, Dr. Sonia Reed, are actively working on. And then we're continuing to recruit for our impact study, which is focused on testing resources to improve follow-up care in individuals with inherited cancer. So the trial's underway. I think we're more than halfway through. So please continue to refer to ICARE for consideration in this trial. And then social media, we are active on social media. Consider following us at Inherited Cancer, either on your social media platform of choice. And these are some examples of what we've put out this past month. But again, we post all of our talks, newsletters, studies that are recruiting, research updates, as well as clinical updates. So with that, I wanted to go right into introducing our guest panelists today. So we have a really phenomenal lineup with Sarah Roth, who is a genetic counselor and PhD candidate in the Department of Anthropology at Johns Hopkins. Sasha Weiss, who is a graduate student in the Department of American Studies at Indiana University, and Kim Zayhowski, who is a genetic counselor and clinical researcher and assistant professor at Boston University. Next slide, please. And they are going to talk to us about care for gender diverse individuals with or at risk for inherited cancer predisposition. So take it away, guys. I think you're muted.
Yes, sorry, the unmute button went away when the slides came on, but hi everyone, sorry, my name's Kim. I use she, her pronouns. Thank you so much for being here today. I'm excited to present alongside Sarah and Sasha, and neither of us, unfortunately, or none of us, unfortunately, have any conflicts of interest to disclose. Basically, what I'm going to do before Sarah and Sasha talk is just set some background for us all to think about before they dive into a lot of the psychosocial considerations and taking care of trans and gender diverse folks. And in this conversation, we're going to be talking a lot about the differences between sex and gender. Just to get us all on the same page, sex is typically assigned at birth based on external genitalia, but certainly there are many different components to sex, such as genes and chromosomes, hormonal malo and genitalia, for example, whereas gender is one's personal awareness of being a man, a woman, a non-binary person, another gender, or many genders. And I think a lot of us can recognize the importance of sex as it applies to cancer risk. But throughout this presentation, we're hoping to show that gender is also a very important consideration when taking care of folks. And LGBT culture is far from a recent or Western phenomenon. You know, fluidity in gender, sexuality, and the performance of such roles is evident in many cultures across the world, particularly before Christianity and a Western influence spread. For example, in Southeast Asian cultures, non-binary gender expression plays an important role and has for over 2,000 years with hijras. In indigenous culture, there are people who are two-spirit. Queer love has been represented in ancient Egyptian tombs. So, you know, the gender binary and the sex binary is really rooted in Western colonization and Eurocentric thought. But cultures have had more than two genders, porous boundaries between genders, or no genders at all. And the LGBTQIA community is a growing community. There are statistics that show about 6% of folks in the US identify as lesbian, gay, or bisexual. About 1% of folks are transgender. And with people under 30, that jumps up to about 5%. About 2% of folks are born with intersex traits, and that's about the same amount of folks that are born with naturally red hair. And so this is a large community of people that we're going to be taking care of and that we are taking care of. So we really need to think about how we can do this in the best way. And I think we'd be remiss to talk about transgender healthcare if we didn't acknowledge the current climate of LGBTQ safety. You know, the Human Rights Campaign, which is a LGBT advocacy organization, recently declared their first national state of emergency for LGBTQ Americans based on the legislative onslaught that is specifically targeting the LGBTQIA community. And many of these pieces of legislation are specifically targeting the trans community. There are over 66 countries across the world that explicitly criminalize same-sex sexual behavior. In fact, I was just in Europe for a talk and found out that there were over 6 countries in Europe that allow forced sterilization of transgender folks. So, you know, it's not just nationally, but worldwide, it is really unsafe to be transgender, even though, you know, transgender identities are becoming more, there's more cultural awareness around these identities. And this actually was from a few weeks ago, but now this has increased. There are over 500 different bills that are being proposed across the US that specifically target LGBTQ people. And many of these bills are specifically targeting the transgender community through things like bathroom bans, sports bans, education bans, bans in gender affirming care. And so, you know, again, it's just a particularly unsafe time to be transgender. And if we're thinking about healthcare, there are lots of different reasons that there's tension between the LGBTQIA community and the medical system. You know, the medical system is made up of institutions that interface with other institutions like the government, research, academia. But there is a current and historical discriminatory practices within these. The medical system has not earned the trust of the trans community. The medical system tends to pathologize differences like sexual orientation, sex characteristics, whereas core parts of queer culture are to celebrate the freedom of self-determination, to celebrate existing outside of categories. The medical system tends to use strict categorization in order to figure out what care people need. And, you know, in the medical system, we're always looking towards the past for evidence for how to best take care of folks. But this becomes impossible with the LGBTQIA community because of how we're collecting information about sex, gender, and sexuality. LGBTQIA identities have largely been erased from research practices, which means that we don't have a lot of the information we need to best take care of the LGBTQIA community. And I think this is particularly pertinent in the cancer realm. So to dive into the cancer realm, if it will change slides. You know, as I've just shown and talked about, the transgender and gender diverse community is a significant portion of the population, yet they're underrepresented in research. There are no large national cancer registries that collect data about both sexual orientation and gender identity, and this cycle of exclusion from the production of medical knowledge impacts the care that we give. And to get a little bit more into those genetics inequities, there have been numerous studies that have shown specific issues in this setting. For example, trans patients have expressed that there's anxiety for genetics consults because of reasonable fear of discrimination, for example. There are many gaps in genetics care that need addressing in terms of how gender affirmation impacts cancer risk. For example, there's uncertainty with how hormones impact cancer risk. There are no firm research or guidelines regarding cancer risk and gender affirming hormones, and certainly no research within the realm of also having a pathogenic variant in a cancer gene. Yet despite this, we've seen clinicians gatekeeping hormone prescriptions due to a fear of cancer risk, which then makes gender diverse patients less likely to seek clinician care for fear of losing or not being prescribed hormones. There are also differences between gender affirming surgeries and prophylactic cancer surgeries. For example, top surgery is a common gender affirming surgery that does not remove all of the chest tissue, so it's not as extensive as a prophylactic mastectomy. This means those who undergo top surgery can still develop breast cancer. And so someone who has a large family history of breast cancer or who has a pathogenic variant in one of these genes might want to consider genetic testing prior to surgery, as it could impact the discussions about how much tissue should be removed. There's also uncertainty in screening regarding cancer for folks who've had gender affirmation surgeries. For example, vaginoplasties don't typically remove the prostate, and so prostate cancer screening should still be recommended to those who've had that surgery. There have been a couple studies now that show that some trans patients come to cancer genetics clinics hoping to have a hereditary cancer syndrome in order to obtain insurance coverage for surgeries like a mastectomy. And I think this just really shows how our medical system and the insurance system has failed the trans community, that folks are hoping for a loophole in the process to have a hereditary cancer risk in order to achieve necessary gender affirmation because of all these gender affirming bans, for example. And finally, there are also considerations for minors. In general, cancer genetic testing is not recommended to minors unless it's medically necessary. However, many gender diverse adolescents considering gender affirming care might wonder if they have a hereditary cancer risk to help inform that care. And if someone's considering top surgery, for example, genetic testing might be important. That could change their surgery. That would certainly be a reason to test a minor. For folks considering hormones, it's a bit trickier. As we just discussed, we don't have great guidance regarding hormones and cancer risk. And so a hereditary cancer risk should not be a barrier for someone to get hormones if that is what they need. However, for some considering hormones, maybe it'll impact their personal decisions or how they perceive cancer risk. Maybe someone's on the fence about hormones and knowing a hereditary cancer risk would push them one way. If that's the case, genetic testing could inform those conversations and that person's own perceptions of their cancer. And I also want to shout out that recent NCCN guidelines have now updated in the breast, ovarian, and pancreatic hereditary cancer section that now has considerations for gender diverse folks. And I think that is wonderful. However, even those guidelines state that there's really limited research that is helping guiding those recommendations. Thank you so much. And I'm going to pass it over to Sarah.
Great. Thanks so much, Kim. My name is Sarah. I use she, they pronouns, and I will dive right in. So as Kim so eloquently just discussed, in addition to facing widespread disparities, trans folks are generally underrepresented in medical and epidemiological literature, which creates these exclusions from data sets on the one hand and standards of care on the other hand. This is especially notable in oncology, where we could say that risk figures are inscribed with presumed gender as a result of this. In a recent genetic counseling thesis study, I was an investigator on a project addressing these gaps and needs, and that is what I'll be discussing here with you today. So for this project last year, I interviewed 19 gender diverse folks, the majority of whom had BRCA1 or 2 pathogenic variants, were in their 20s or 30s, and were non-binary or genderqueer. They were also mostly white, as this is generally what the participants in patient advocacy groups look like, which is where most participants found out about this study. This wasn't a terribly big surprise. So after looking over transcripts and recordings from interviews, as well as field notes, I moved between interviews and the existing literature to articulate three main themes to highlight, and that's mostly what I'll be talking about today. Firstly, interviewees described experiences of discrimination and dysphoria as they navigated care experiences and environments. They also shared narratives of gender identity and genetic diagnosis intertwining in terms of access to interventions, shifting relationships to gender expression, and navigating multivalent forms of medical uncertainty. Throughout interviews, participants also shared their aspirations for what hereditary cancer care could or should look like for queer and trans folks navigating it. So across interviews, folks pointed to what anthropologist Lachlan Jane has called the redoubling of femininity in cancer care, marking experiences of dis-ease they had navigating interactions and care environments. As one interviewee noted, the gendering of these care spaces doesn't end, it's everywhere. Many participants also specifically reflected this remark by Ben, a trans BRCA2 carrier, that the worst clinical passage point was the waiting rooms. They also pointed to screening appointments and interactions with admins and techs as especially difficult, as these were the most common places where they were misgendered. Interviewees really explored the social and emotional ways that they responded to these experiences, in particular describing how they would brace for misgendering in advance of appointments. And this supports LIT documenting trans experiences of anticipatory anxiety around genetic and counseling encounters specifically. That role has described in a recent article in the Journal of Genetic Counseling. This really suggests that cancer genetic counselors and folks working in oncology can anticipate anxiety from their clients from previous experiences of mistreatment, and this really calls for specialized compassionate care in this context. So participants also explored the complex ways in which their care journeys intertwined. This theme from interviews is really at the heart of our study, and article manuscript currently under review is also dear to me as a queer BRCA1 carrier myself. So as Fern, the interviewee highlighted here, described in their interview, care experiences were tied up or interlaced together. For many, cancer risk presented a crossroads in gender expression. So this question of how to respond to embodied risk, prophylactic recommendations, or an experience of disease. Among participants who had begun the process of managing the cancer risk, a lot of people expressed feeling affirmed by receiving mastectomy without reconstruction. As Jay, a non-binary BRCA1 carrier, noted, it's multiple weights off my chest because it's gender, it's cancer risk, it's, self-image, it's everything. Some participants also shared that receiving a genetic diagnosis enabled them to overcome barriers to gender-affirming care, specifically through insurance coverage for surgeries. As Ben discussed, the biggest thing in all this was that it allowed him to get gender-affirming care. And he said, frankly, I wouldn't have been able to afford it all without the genetic diagnosis. And finally, with regards to intertwining journeys, navigating hereditary cancer care and gender-affirming care together brought up a wide range of intense mixed feelings for participants. In describing their experience, Jax, a non-binary BRCA1 carrier, noted that there was the euphoria of inhabiting a body expressive of the gender that they felt, but also the trauma of trying to survive cancer. Navigating cancer care, they felt like they were moving between these experiences of trauma and euphoria. Now there are new slides. Sorry for pausing for so long on that one. So as folks navigated largely unwelcoming environments and complex care experiences, interviewees also shared about experiences that were affirming or gave them insight on a future they would like to see in hereditary cancer care. Jason, a non-binary BRCA2 carrier, reflected on how it felt when a clinician honored their non-binary identity shared on an intake form. I feel like my identity is included in the room, they said, rather than just my biology. Reflecting on their experiences and needs, participants shared that they appreciated when providers communicated allyship implicitly or explicitly through cues, pins, or lanyards, were attentive to gendered language, partnered around difficult and complex care decisions, and validated and normalized their preferences. Participants also expressed a real longing for providers to work to hold space for the emotional complexity of being a carrier or being a previvor. So living with cancer risk over time and through many different care junctures, not just the one juncture that they found themselves presenting with at this point. So as I conclude, I thought I'd spend my last couple moments discussing a couple ways that providers can use these insights to work more inclusively with patients and communities, since the majority of folks present are likely providers working in these or allied spaces. So in the context of complex care journeys and keeping in mind, as Kim referenced, mounting attempts to censor trans existence in the US as well as around the world, it's important to consider how we can build trust with queer and trans clients and community members. So in addition to listening well, asking for pronouns and conveying allyship, we can also ask for input on a family tree as we document it for those of us who work with family trees clinically. We can partner through counseling around experiences of dysphoria. We can also use gender neutral or patient first language to describe the body. So patient first, meaning following the lead of the patient and the language that they use to describe the body. We can also, especially in cancer genetic counseling, explore gender identity and expression in the clinic. And we can do so really by using our counseling skills to compassionately explore gender. So asking open-ended questions, following leads on language around labels, and exploring what a client's vision for gender affirmation looks like or could look like. That said, people don't always come into a counseling session or an oncology appointment expecting to really become vulnerable and share that vulnerability with a clinician. And they may be primed by the aforementioned difficult passage points before reaching clinicians. So it's also very important to be cognizant of that and not demand vulnerability and openness. Finally, as clinicians, we can refer clients to support, and there's no reason not to refer to queer-friendly support and affinity group offerings. So here is some information about Forces recurring LGBTQ support group, which I'm happy to provide additional information about, as well as the Breasties recurring virtual group. And both of these groups host monthly virtual groups that are accessible from anywhere. They aren't perfect, but they do provide a kind of support and affinity that is hard to find elsewhere. With that, I would like to offer my thanks to Tuya for inviting us, and I will pass the mic over to Sasha, who will share more about their story.
Hi, everybody. I don't have any slides because I'm here as a patient rather than as a researcher, although I do research in this field as well. But I'm a trans guy. I know I don't necessarily look like what you expect when you hear the words trans guy. And that's actually a big part of what I want to talk about, which is that you won't always know who your trans patients are just from looking at them. Like some people are, the term we use in the community is clocky, like, which means like you can kind of tell just from looking at somebody that they are probably transgender, like maybe they have facial hair but really long hair and otherwise like feminine presentation, or maybe they're like really short and have a somewhat feminine face but they're dressed very masculine. Like some people you can tell, but most of the time you won't be able to because there's such a diversity in the trans and gender diverse community. Like some people pass really well, some people look like the gender that they feel like, and others, like myself, no matter what we do, kind of always get read as the gender we were assigned at birth. And there's really not that much that you can do about it in a lot of ways. And I think like it's really important to keep that in mind as a provider, because like a lot of these steps that Sarah and Kim have introduced are incredibly helpful, but like they're helpful when you do them all of the time. So like if you make your clinic a safe space for queer and trans people by having a pin on your lanyard or your badge that says like my pronouns are she, her, he, him, they, them, whatever, then you don't have to like know for a fact that you're interacting with a queer person to have a dramatic effect on how safe they feel in your presence and in your clinic. Like it makes a world of difference even when people aren't ready to be vulnerable with you in that way. So I guess I should say a bit about my story. I have a BRCA1 mutation and I was diagnosed at 22. I'm now 27. So I've been living the pre-Viver life for about 5 years now. And it wasn't a huge shock to me. I'm Ashkenazi, so, you know, it comes with the territory. At the time I was diagnosed, I was very convinced I was a cis woman. And if you asked me, I would have said I'm a cis woman and my pronouns are she, her. And I was very, very convinced of this. And ultimately, I only kind of started to wonder about other possibilities because of and through the process of learning to live with this mutation and this risk. Because as much as we try and talk about how things like cancer risk are just a part of life and you learn to live with them, and like people act like it's just a thing that happens and it doesn't really change who you are. In a lot of ways, it does. Like, it's not so much about the drastic physical changes that can come with like cancer prevention measures such as surgeries. It's more about like, there's kind of a deep-seated psychological trauma that comes with being told that on a fundamental level, there is something wrong with your genetics. Like, that's always been there and always will be there. Although with the recent news about CRISPR treatments for sickle cell, you know, maybe there's a future in which this is something people don't have to live with. But for myself, I found that the hardest part of adjusting wasn't the possibility that I would get cancer so much as the realization that on a fundamental level, there was something about my body that I had no awareness of until suddenly, oh, I'm aware of this gene mutation that I've had my entire life. And it felt like I didn't know myself, which is a kind of disturbing feeling. And it called up a lot of questions like, well, if I didn't know something this fundamental about myself, like what else don't I understand about the person I am? And the process of learning to adjust to and screen and treat these risks also involves sort of a changing attitude to your own organs, for lack of a better term. Like, I didn't hate my breasts when I had them. I wasn't particularly dysphoric about my chest. I wasn't particularly thrilled about it either. But when I learned that I had this risk to live with, it's kind of embarrassing to say, but I'll say it anyway. I didn't change my shirt for the entire month between finding out and it was only a month because I was a pre-med student, so I had actually given a lot of thought to what I would do in this exact circumstance. So I knew that the tits come off. The tits come off. I don't want to deal with this hanging over my head. And so I scheduled surgery a month after I got my diagnosis, just so I could get on with my life. And for that entire month, I couldn't look myself in the mirror. I couldn't change my bra. I took it off to shower and I put it back on and I wore the same baggy sweater every single day. And it was gross. And I don't recommend it, but it was what I needed to do because I really felt like I couldn't relate to the body I had anymore. And I didn't figure out for a very long time that that was a gender-related feeling. I thought it was just like a way of getting through a really difficult time in my life. But over several years of sitting with that feeling and like being around other trans people, I sort of started to think like, oh, you know, maybe there's something to the fact that I feel better standing up straight rather than slouching to hide my chest now that I've had this surgery. Like maybe there's something to that I should think about some more. And it's been this really interesting, interlaced was the word Sarah used, and I think that's a great term for it, journey of self-discovery. And I think that's like something that I want doctors to take away, is that your patient's feelings about this might change dramatically over time, and that's totally normal and okay. Like, gender is a process in the same way that none of us feel like the same gender we felt when we were children. Like, you don't wear the same clothes you did as a 5-year-old. I wore butterfly hair clips. Even if I were still a cis woman, I probably wouldn't wear butterfly hair clips now to express that. It's just different. Kids don't wear high heels. Like, gender changes for everybody. And I guess if I could tell anything to you guys, and I'm really grateful for the opportunity to tell this to you guys, the best experiences I've had with doctors about this is when they treat me like this is just another part of who I am. Don't make too big a deal of it, but also don't ignore it. Like, when I came out to my surgeon, she was like, okay, cool. Yeah, thanks for letting me know. It's totally fine if you go on hormones. Like, there's not a lot of data, but like, I will still treat you exactly the same and we'll still manage your risk exactly the same. And I really appreciated that, because she was the first doctor I felt comfortable telling that to, because I've had so many surgeons look at me and go, here is what you should do. Here is the strategy. Have your ovaries out at 40, have children. Don't worry, you can still have children. And I'm like, I'm not worried about that. I don't want, like, that's a big assumption to make. It's a big assumption to make about anybody that they want to carry a child. But like, I'm a guy. I'm not interested in that. Some guys are, but I'm not. And I think another thing is, like, there are more of us than you think. Like, when I went to talk to a doctor about starting hormones, I got really lucky. Turned out my HRT prescriber is a trans guy living with Lynch syndrome, which I had no idea about when I called to set up the appointment. And he was like, I see you have a BRCA mutation. I just want you to know, like, I've been there and I don't have cancer. So, like, don't be scared by this big empty question mark of, well, does it affect risk? Because everything affects risk. Like, we could all exercise more, that would lower our risk. It's not a reason to deny people something that's really necessary to their well-being. And I guess I just want to say, like, as a trans person with a BRCA mutation, it means the absolute world that there's a meeting like this happening. Because, like, I'm a little bit frazzled because I'm very emotional about it. Like, I can't imagine having this kind of space being held 5 years ago when I was diagnosed. I literally can't imagine doctors even realizing that this was an unmet need, let alone like caring enough to gather together and make space to talk about it. It's been ignored for so long that patients like me didn't even know this was an option. Like, I didn't even know that having surgery could change how I felt about my body in such a wonderful and scary and interesting way. And like, I'm so grateful that my doctors have made space for that. And I'm so grateful that you are making space for that, because your patients, regardless of whether they're cis or trans, will benefit from this kind of empathy and this kind of understanding. So yeah, thank you.
Thank you so much, all three of you. I mean, again, I personally have learned so much from all of you. And, you know, I'm just going to say, even for Sarah and Sasha, I think it's because of you all that I started realizing the pronouns thing, because it is important. And I added that to my signature specifically from discussions with you guys. So again, really, really appreciate you being here, sharing your stories, sharing your research, sharing information. You know, we're going to open it up to questions. I also want to just kind of let everyone know, through NCCN, when we developed the guidelines specifically for transgender individuals, we did have feedback. So again, big thank you to both Sarah and Sasha, who were our reviewers behind the scene that we couldn't acknowledge in those guidelines, but it was the first one. And I think I'm hopeful that more will be coming that actually got, you know, puts forth some information But to me, it's food for thought. That's just a first step, right? Because as Sarah already outlined, there's a lot of research to do because we don't know, like in my mind, I feel like we put forth some of the questions, but we don't have answers to them right now. We don't, but at least we've now got a compilation of all the questions that need to be answered to guide care for our patients. But I wanted to see if do you guys have any other comments amongst each other? And then we can open it up, and then we have some cases to discuss as well. Oh, Georgia has a question.
Sorry, everybody. I've got a cold, so glad I'm not there sharing it. I just wanted to say thank you for being vulnerable in sharing your story. And it does help clinicians kind of think about the changing landscape of what patients and are kind of expecting from their providers and how they navigate. And of course, we are in Tennessee, that is a very restrictive state. And I think even the act of putting pronoun identifiers is a big deal here. And so I just wanted to say thank you, because this is a big deal, and I know that you're opening up. One thing that I think is so important, though, is, and Sarah or Kim, I can't remember which one of your talks, I was thinking, well, where are we going to get these data that are needed so much to say, well, how big is the risk? If you take hormones and you adjust your hormone and how big is that? Because we're so risk-based on, if we have this and we have this gene and we do this, how are we going to handle those eventual risks? So it's really, how are we going to generate the data that we really, really need in order to make these cogent decisions for people? So that's my soapbox for the day, and I'll stop it.
I'd like to respond to that. Thank you so much. I used to work in medical research, so if I had infinite funding and also like the resources to reach out to people, my dream study would be a large cohort, like national, virtually handled natural history study that looks at people for decades through their hormone journeys, through their cancer risk journeys, and like just takes note of what dosing, how the dosing changes over time, what kinds of screening have been done, the genetics, and also just like whether or not they end up getting cancer, and if so, what types. And like, unfortunately, we're going to be the experimental generation, but there's always going to be an experimental generation. And I think that like, there are some elements of that kind of research being done. The PRIDE study out of Stanford doesn't focus on cancer risk, but it is gathering large amounts of broad epidemiological data on like what kinds of health experiences trans and queer patients are having, as well as like what diagnoses they have, what gender affirming care they get over a year, and people fill it out annually. It's a survey, and there's been quite a wide range of data coming out of that. And it's not cancer specific, but it is a great model for the types of research that could be done.
Are there any registries focused on inherited cancers for trans individuals? Like at a registry level, is anything being done where, because again, we have trans individuals in our registry, and I would be more than happy to like make them aware of other focused research efforts if we were aware of any, but I just don't know of any.
Yeah, I personally don't know of any either. And I also think there should be I think it goes to show the need to collect data about sex and gender on like national cancer registries, period, to get this kind of broad data. And it shows the long lasting impact of not collecting this kind of data systematically in studies that aren't even just specific to trans folks. The other thing, I mean, to George's point, I think there is, given the current legislation and kind of like in some states lack of medical privacy too, I think it makes it really challenging, because in situations where you don't think your data is private, why would patients reveal like aspects of themselves to you? And so I think that legislative landscape is making it very complicated to do this kind of research that is ultimately putting the burden of cancer disproportionately on trans folks. Like, we can't be telling trans folks, I don't know if your risk for breast cancer is 12 or 84%. Like, if you have a BRCA variant, for example, that's unacceptable. But right now, that's the situation that we're in with our patients, and we can't be more specific.
So we have a question for Sasha. So Sasha, keeping in mind that your perspective is not representative of the entire community, but what was or what would be your preferred way to discuss the hormone and surgery consideration plan or progress when doing a genetic risk assessment? Is there specific language to use or avoid, which I think, all of us would find super helpful.
Absolutely. So, in my experience, I've seen like 6 different surgeons over the last 5 years, and there's a reason for that, which is I had an excellent breast surgeon. She met me where I was. She listened to my concerns, and she was like, yeah, I'm here to provide information. I'm here to meet you where you need, like, with what you need, and like it's not the choice I would make for myself to have like flat closure mastectomy at 22, but I understand that you have given this a lot of thought, so I'm happy to provide that procedure to you because it is indicated. And I really appreciated that, because it's like, regardless of whether you're cis or trans, there's no one way to handle this kind of news. It's a lifelong process, and your attitudes and your opinions about your body and what you want to do for your risk management change so dramatically over time. I ended up having 4 different gynecological oncologists that I've gone through, because the first 3 looked at me and said, for various reasons, you're too young to be thinking about these risks, even though you're thinking about them. And there's no valid reason for you to be thinking about them in your 20s, because your ovarian risk doesn't go up yet. And I'm like, I'm mostly here for gender reasons though, like, hi. And they're like, it was so beyond like what they had on their radar that they just kept saying, no, I'll see you in 10 years, goodbye. And it's kind of like you do have to, Robin said in the chat, you do have to discuss firing a provider if you're not super comfortable. And ultimately I've had to do that a few times, because it's like, if people just can't understand where you're coming from, then it's not like, how are you going to feel safe with them? Because there's so much vulnerability inherent to going under the knife. Like, we don't talk about it because it's our normal, right? For both patients and providers, it's what we do. It's how we survive. But Kim mentioned earlier the problem with forced sterilization of trans people. That's a really big concern. And it's also a really big concern with respect to like the gender elements of like mastectomy as well. Like, there are so many people who have had to have revision surgeries because their surgeons consented them for flat closure mastectomy and then didn't do flat closure mastectomy because they know better. It's a really serious problem. And I think that for me, the ideal is finding a provider who will listen to where I'm coming from and why I want to handle my risks the way I want to handle them, and just like accept that. Because it's like, I get that it's not the way everybody would act with the risks I have, but like ultimately I'm the one who has to live with the outcomes. And so my oncologist, who I love so much, she's amazing. The reason I love her so much is because she like took what I was saying at face value. And when I came out to her as trans and said I was considering hormones, she was like, cool, like, I'm going to no nonsense tell you that we don't have very much information, but I'm not going to say that that's a reason not to pursue the care that you want. And I've gotten the same kind of feedback from my HRT provider, who has Lynch syndrome himself, who said like, yeah, I made a similar choice and I have not regretted it. And like, yeah, I think it's one of those things where like, in most of medicine, doctors have the expertise, right? Like, if you have the flu, doctors know how to treat you. You don't know how to fix it. If you have a diagnosis of cancer, you don't know what chemotherapy to take unless you're an oncologist. But with something like this, it's ultimately about like planning out the next 5 to 10 years of your life, how you want your body to look, and whether or not you'll feel comfortable taking on that kind of risk and living with that kind of change. And that's a very different and much more emotionally engaged process. So it's very much more a conversation peer to peer than it is like your standard doctor-patient power dynamic. And I think that's the ultimate takeaway, is that like the work that you guys do is a very particular, very open and vulnerable kind of space to operate in for everybody involved, regardless of whether or not gender is a big deal in the conversation. Hope
You
that
know,
helps.
Sasha, what you described as shared decision-making. So maybe that's the terminology that we should start talking about when we are discussing this. Is I don't know. And Kim, I think you saw there's some other questions for, it's not a question for you in the chat. Can you elaborate? So this is from my colleague at Vanderbilt, Kate Mittendorf. Can you elaborate for clinicians here what you meant by pathologization of differences? I think providers, even well-meaning ones, can fall into this trap. And can you elaborate more on how not to do this? And Sasha may have input as well.
Yeah, well, this could be a long answer, but let's see. So I think there are a lot of ways that we can look at history and how we've pathologized LGBTQIA people, and a lot of it is still happening today. And it's how we're labeling people as having a disorder or a condition for being queer, for being trans, and how we make folks undergo so many more barriers to care because we think that their identities are disorders. We see this with a lot of different things. We see this with how people treat race as a biological factor when that's not actually what causes healthcare disparities. It's racism, it's white supremacy. The same thing happens for trans folks and gender diverse folks. You know, it's not being trans in itself that is causing X, Y, and Z health disparity. It is transphobia. It is providers not being comfortable or safe for people to go to. And that's what causes people to avoid medical care, or that's what causes like increase in mental health conditions, for example. Like, I think that a lot of people say, oh, it's the transness that does that. No, that's just not taking ownership of how we are all implicated in that. Throughout genetics, we can see research studies that are like trying to find trans genes and trying to find gay genes. And that's just inherently pathologizing gay, trans, LGBT people at large, because it's saying, oh, straight is normal, being cis is normal, being trans is not. That's a mutation. That's what causes that identity. So I think there are a lot of different ways that the medical system really contributes to the othering and pathologization of trans folks, which contributes to larger health disparities. If you see all these legislative pieces, a lot of them are saying sex chromosomes are what determines someone's gender. And that's just not true. As we're talking about, sex and gender are entirely different concepts. And to be honest, sex chromosomes are just only one aspect that contribute to sex, but there are lots of other aspects that contribute to sex. And so even when we're talking about sex assigned at birth, that's really non-specific. That's just saying this is what was on your birth certificate, probably based on your genitalia. And so, you know, in cancer, tying this back to cancer care, I think we need to be a lot more explicit and specific about what aspects of sex we're thinking about, what aspects of gender we're thinking about, doing organ inventories. There are lots of different reasons that people don't have ovaries, for example. And so I think that we're not being precise at all in how we're providing care, even though the promise of genetics is this precision medicine.
Sasha, do you have anything to add?
Yeah, I do. I think that exactly what Kim said, especially with respect to the ways that people think of transness or queerness in general as like a disease. Like, it's very, very common for people to talk to like young queer people who've just maybe come out as saying like, oh, it's a phase, or oh, you don't understand yourself. Like, this is far beyond the medical system. This is just something that permeates American culture in a very big way. And I've noticed that like when I talk about the relationship between my own gender experience and my experiences as a pre-vivor and how tied up they are, I've gotten a lot of people saying, well, how do you know your transness isn't a trauma response? And yeah, like my parents have said this to me. Like, they think that I am saying I'm trans as a way to feel better about my cancer syndrome. But what that view misses is that I don't feel better about my cancer syndrome. Like, it's great that I get to have some gender affirming care under insurance through cancer prevention. That's icing on a cake, but it's a crappy cake. Like, nobody wants to have a cancer syndrome. I mean, like, my aunt died and I live with a bunch of survivor's guilt now, and I have to worry about my younger relatives and whether or not my own struggles with this will shape their decisions about whether or not to get tested, and I don't want to live with that guilt. Like, it's terrifying. I'm going to see my oncologist for screening next week, and it's like keeping me up at night because it's hard. But it did open a door for me, and I think that's something that's really important to think about, is like, some people may find the door to wondering whether or not they're not cis opened by things like this, because our society tells you so much from birth. You're a girl, you're a boy, you like trucks, you play with Barbie dolls, like whatever. And it's so ingrained in our society to think in this binary way that, like, it really does take sometimes a traumatic experience to change how you're looking at the situation in a way that actually gives you the space to think about it. It's like, I think there are many things that could have helped me realize I was trans. And if I look back on my childhood, there were all kinds of signs. There are so many signs. From the time I was 11 and I learned what periods were, I was wishing for menopause because I felt so dysphoric about my own body and I just didn't have the language for it. And there was no space in my childhood to say, well, are you sure you're a girl? Of course I'm a girl, because everyone told me I was, because I have a vagina, I must be a girl. And it's like, if our society gave people space to consider it, that there are other possibilities, then we wouldn't end up having stories like mine, where ultimately it was some bizarre series of events that led to me thinking about these things from a new perspective. But like, just because of the context in which somebody discovers things about themselves like that they might be trans doesn't mean it's a trauma response. And it doesn't mean it's like pathologized or that it should be pathologized, because ultimately, I mean, I learned a lot of things from my mastectomy, like how much easier it is to do the dishes and run upstairs without double D breasts. Or like how much easier it is to go for a jog without double D breasts, or how much likelier I am to exercise because I don't have to put on a sports bra. Like, you learn all kinds of things about yourself. I learned that if you don't have nipples, you forget that they exist. And then when you see them on somebody, you get scared because you forgot they existed. Like, there's so much you can learn from this kind of experience. And none of those things I'm never told that those things are trauma responses. But I am told that the gender things are, because that's how we're trained to think about it, as a pathology, as a problem to be solved. And it's not.
Yeah, that is very insightful. Let's go on to our case, because I think you guys will be interested in, we'll at least be able to get this first case done, but I think it will highlight a lot of what you all have already discussed, and then we can discuss it as well. Mariah, take it away.
All right, my name is Mariah Hubert. My pronouns are she, her. I'm a genetic counselor at Vanderbilt, and I know we're running short on time, but I just want to thank the presenters so much. This has been such a wonderful presentation and super helpful. I'm actually going to pass over the case presentation to Cece Kessler, who is a genetic counseling student here at Vanderbilt that saw this patient with me.
Yeah, my name's Cece or Cecilia. I use she, her pronouns. But we had the pleasure of meeting with a patient the other week, and it was just a very interesting case. And overall, this session, I think, highlights a lot of the themes we've been talking about today, and just the challenges of providing, or I guess the challenges transgender and gender diverse patients face. And I hope that this case kind of highlights why these conversations that we're having today are just super important and need to continue. But we saw a patient who was a 34-year-old transgender male. They had a clinical diagnosis of classic FAP and a known pathogenic APC variant. They were referred to discuss his genetic test results, as well as management recommendations for FAP. And we'll talk a little bit more about some of the social implications at play, but I think it's important to note that this patient, he came in and he informed us that he is estranged from his maternal side of the family. And as you'll see, this is where a lot of the family history of the FAP is coming from. And with genetic conditions, a large part of staying up to date with your genetic condition is the information that's flowing between relatives. So a goal for this patient was kind of just to get up to date with FAP management. But some other social implications were at play here. He had little to no access to gender-inclusive clinics across specialties. So he lives in an outside state and had to drive at least 2 hours to Vanderbilt just to talk to someone who would see him to talk about FAP. And he's had a lot of unaddressed health concerns as well, that he's just been having difficulties connecting with healthcare providers to address those. But he does have a trusted PCP and a trusted healthcare provider or mental health care provider, but he was seeking additional specialists. And he did present with his partner, and he is happy with his support system for the most part outside of his health. So of note, this patient had a colectomy at the age of 15 due to the maternal history of FAP. What was interesting was that just the age that this was done at, but also he mentioned that he wasn't part of the discussion for the procedure, and he felt that that decision-making power was taken away from him when deciding whether to get a colectomy or not. And then while part of the session was talking about FAP management, we did spend quite a while talking about his complex medical history, which also included multiple thyroid nodules, multiple episodes of fainting and dissociating, which sounded a little bit like POTS. He had concerns for EDS. He was experiencing heart arrhythmias, abdominal pain that was quite persistent, urinary incontinence, cyst behind the eye, possible spondylosis concerns, and he had anxiety and diagnosed PTSD. And then here's his pedigree. So he came in, had the APC results already. And since he's no longer in contact with his maternal side of the family, he didn't know who has had genetic testing. But when he was still in contact and had his surgery done at the age of 15, the diagnosis of FAP was diagnosed on multiple relatives on that side. And then here are just the genetic testing results. And as you can see, he had genetic testing to confirm that APC variant just a few years ago, and it found this pathogenic variant. But as I mentioned, while part of this visit was discussing NCCN recommendations for FAP management, we did take a lot of time to listen to other compounding concerns that were happening, and we made sure to connect him with providers that he felt comfortable with moving forward. So we referred him to GI to establish care given his FAP diagnosis. We also, given his abdominal symptoms, we wanted to make sure that he was getting evaluated for possible desmoid tumors. He was interested in a neurology referral, given the potential spondylosis and other nerve-related concerns and pain. And we also referred him to general genetics just for a proper evaluation of EDS, since he's never had workup for EDS, and there were some symptoms he mentioned that, did cause concern there. And as I mentioned, this patient is no longer in contact with most of his maternal side, and is just unsure if any maternal relatives have had testing, and just hasn't really had any information about APC given to him from that side of the family. And when talking to him and learning about how he's had his clinical care managed, he did review quite a lot of challenges he's faced. So not only has he had difficulties accessing healthcare providers, but when he's met with healthcare providers in the past he could access, he's had struggles having providers actually listen to him. There have been cases where he has told providers his pronouns and his chosen name, and not only have providers refused to use his chosen name, but they have made fun of that chosen name. He's also had healthcare providers straight up refuse to see him just because of his gender identity. And it was really upsetting to hear. And I told him in the appointment that I was surprised that given all of the things he's been through, he still has trust in the medical system and still shows up, was at his appointment today. And he told me that he's learned to use his frustration as motivation because he doesn't want to let the mistreatment he's had in the past prevent him from accessing quality health care. And I just think, it's such a shame that the burden of him accessing quality healthcare is specifically on him and to navigate his, frustration. So he was really happy with the plan moving forward, and we're hoping that some of these referrals will help connect him to providers who can answer some of his questions. But yeah, there's just a lot of challenges that came up during this appointment that I thought were quite significant and representative of, how there are so many barriers in providing efficient care for this patient population.
Thank you so much, Cece. I know we're out of time, but I would love to have any comments from our panelists on this case, which, again, to me, highlights a lot of what you all already talked about as challenges. But any additional thoughts or perspectives or comments on this
Actually,
case?
I do have just a question about the types of surgeries that this particular patient might have had. For example, bottom surgery, top surgery, would that make a difference? Did that impede the type of surgery he'd had? Because he'd had a colectomy, and I don't know how he eventually was put together, but that could impact any other types of surgery he might have. So has that been an issue for this particular patient?
I don't think that came up too much. The patient has had a hysterectomy and oophorectomy, but yeah, we didn't discuss any other type of gender affirming surgery in relation to FAP.
Yeah.
And there's another question in the chat, I think you guys might have seen, from Kate and my colleague Kate. Also, we always talk about prophylactic mastectomy versus gender affirming chest reconstruction, but given this case is APC, can either of the clinical panelists talk about choice of vaginoplasty, bottom surgery techniques in trans feminine patients with a colorectal cancer risk, e.g. choice of intestinal vaginoplasty versus other vaginoplasty techniques?
Yeah, that's a really good question, Kate. And honestly, it's not a question I've thought about before, and I would definitely have to look into and want to talk to a surgeon about, but I don't have a good answer for that.
Yeah, I unfortunately don't either, but it's very good food for thought and research and further investigation, and kind of draws my own attention to the limitations of my knowledge about different surgical techniques and their implications. So thank you for bringing it to our attention.
Any other closing? I know we are over time. I apologize for that, but this was such a phenomenal case conference. I know we still have a number of attendees. If not, I'm just going to go to our last slide. We have, again, a lineup of really phenomenal case conferences coming up next year. Big thank you to our three panelists today, Sarah, Sasha, and Kim, for really a very insightful presentation and perspectives. I think across the board, all of us have learned a lot. And, I do find learning from individuals who are very passionate about this area and who have had lived experiences is very different from what you read in a textbook or in a paper. So, heartfelt thanks for agreeing to do this. I would love to invite you guys back as time, progresses, maybe next year at some point, because I think this is going to be an ongoing, very interesting area that we need to expand and make sure that we're taking care of our patients the best way we know how. Again, just from my perspective, you're right. Like when we're talking about normal versus not normal, we need to really revisit that, right? And we even I do a lot of disparities work based on race, and it's kind of the same thing, right? Like as I'm thinking about it, we always use white as the referent group, and then everyone is compared to white. And even the top journals are now reconsidering what we're doing. So I think as a society, this gives us a lot of food for thought that we can't really lump people into normal and not normal, because that's not normal is, and even someone with a mutation, we can't. And I'm very clear in counseling sessions, we all have mutations. Just because you have a mutation, it's not that you're not normal, right? So anyways, thank you all for agreeing to do this. Really, really appreciate it. Next slide, please. So our next case conference will be in January. Thank you to everyone for attending, and we will be in touch. And if anyone wants any additional information or to contact any of our speakers, if they're willing, again, more than happy to make any connections that would be helpful. So thank you all. Happy holidays. Take care. Bye.